Good evening, everyone. On behalf of Intas Pharmaceuticals, myself, Dr. Karthik, Senior Medical Advisor from the team, welcomes you all to the 37th episode of Endocrine Talk Show. So, today we are having an interesting topic, which is non hormonal blood tests as clues to endocrine disorders. So nowadays, in the practice of endocrinology, though we have a number of hormonal assays available, critical diagnostic clues often hide within the standard biochemical and immunological screens. So our panel of experts are going to decode those subtle signals through various insightful discussions. So for this, I would like to welcome our anchor of this program, Dr. Professor Shubhankar Chaudhary, sir, who is the director, Department of Diabetes and Endocrinology from Medica Super Specialty Hospital, Kolkata, and former head, Department of Endocrinology from IPGMR and SSKM Hospital, Kolkata. So he's an immediate past editor-in-chief of Indian Journal of Endocrinology and Metabolism. He's a past president of ESI, an immediate past president of Endocrine Society of Bengal, and he has more than 220 publications in various national and international journals. So it is with great pleasure I welcome Dr. Shubhankar Chaudhary to take over the session. Over to you, sir.
Thank you very much. A very good evening to all of our friends from across the country. We all know the endocrine system is sort of deep rooted, and its reach is to every tissue, every cell in the body. Therefore, when there is dysfunction of the endocrine system, the manifestations could be diverse, affecting all the different systems that we can think of. And as a consequence, the abnormalities that we see could again reach the very basic tests as well that all the physicians would advise. That gives us an opportunity, even at the very basic level, to try and suspect if there can be any endocrine issue, and therefore we can then initiate further evaluation for proper diagnosis and management. To deal with this interesting area of non-hormonal common blood tests as clues to endocrine disorder, we have four eminent endocrinologists from across the country. And I would encourage all our participants this evening to put in your questions in the chat box. Kindly try and identify yourself as well. We shall try and take your questions as we get along. So we have this evening Dr. Vaishali Deshmukh, who is faculty at Sassoon General Hospital and VJ Medical College, Pune. And she is an excellent speaker, wonderful person, and a great organizer. We also have with us this evening Dr. Pratush Gangadhar, who heads the Department of Endocrinology and is a senior consultant endocrinologist at ICRA Hospital and Research Center at Kozhikode in Kerala. We have amongst us this evening Dr. Shahana Shetty, who is professor and head Department of Endocrinology at Kasturba Medical College at Manipal. And we also have with us Dr. Ankur Gehlot, who is Additional Director, Department of Diabetes and Endocrine Sciences at Rukmani Birla Hospital, Jaipur. So we will straight away get into the episode. And if we start with Dr. Gehlot, so we know anemia is so very common in our country. What would the endocrine disorders that we would suspect if someone presents with anemia? I mean, So many conditions will be there, but which would be the commoner ones that we will think about, that the physician colleague will think about?
Yeah, good evening, everybody. I'm Dr. Ankur Galot from CK Birla, Jaipur. So look, first thing first. So first of thing, we'll think about the most common disease or disorders or endocrine disease, which is there, which is of course thyroid problems. Quite frequently, patients with especially hypothyroidism presents with anemia. So we have to rule out hypothyroidism or even hyperthyroidism in these patients. And now in hypothyroidism, usually the kind of anemia is normocytic, normochromic anemia. So usually you will find normochromic, normocytic, but sometimes you will get hypochromic microcytic anemia if suppose hypothyroidism is associated with celiac disease, or there is some absorption problem with these patients, then there might be hypochromic microcytic anemia. Now the other disorders which we can think is of course adrenal insufficiency. So most of the adrenal insufficiency patient may have may present with normocytic normochromic anemia, but usually the anemia is not so severe. It is subtle anemia. But we should think, especially if patients presents with weight loss, hyperkalemia, slight anemia, then we should think of about the adrenal insufficiency. And sometime hypopit patients, growth hormone deficiency patient, or pituitary patients also presents with different kind of anemia. Normally these anemias are normocytic to microcytic anemia, but sometimes if it is associated with B12 deficiency, then of course we can get megaloblastic or macrocytic anemia. So these are the basic, you
Right,
may say,
right.
endocrine disorders which we should rule out in anemic patients.
Uh, yeah, so absolutely so. And uh, we all know
And one
that,
more, sorry, I
yeah,
forgot to tell
yeah,
one more, that in severe cases of hyperparathyroidism also, you
right.
can have
Okay. No,
anemia.
what was trying to uh, sort of point out is we all know that androgen testosterone is a stimulant for erythropoiesis. So, do we see anemia in hypogonadism, in male hypogonadism?
Yes, of course, because testosterone or androgen is a stimulant as far as erythropoietin secretion is concerned. So these patients may have anemia, especially microcytic hypochromic anemia because of the erythropoietin deficiencies.
Right. So we have a whole host of conditions, hypothyroidism, hypogonadism, any of these which could present with anemia. In most instances, of course, these are not severe anemias.
Yes.
Usually, maybe mild, maybe what? Hemoglobins would be 10, 11, 11-ish, thereabouts. So, Dr. Gellot has already talked about hypochromic microcytic and normochromic normocytic. So, can I ask Dr. Prathos as to what do these RBC indices, what do they tell us? How does it help
Yes,
us? We are
yes,
not
sir.
hematologists, we know,
Yeah,
but still.
yeah. In RBC indices, we have mainly mean corpuscular volume (MCV) and MCH and RDW. These are the important parameters we look in uh, even basic medicine practice. But in endocrinology, as we already discussed, if you have a low MCV and a low MCH, that generally indicates a microcytic hypochromic anemia, and we have to think about iron deficiency. In hypothyroidism, they can have refractory iron deficiency due to multiple reasons. It could be due to blood loss due to menorrhagia in women, but it could be due to coexisting celiac disease. So it can lead to severe iron deficiency, refractory iron deficiency. So it could be hypothyroidism could be a hematological mass. So it not only produces microcytic hypochromic anemia, as Dr. Gallot already mentioned, it could produce a macrocytic anemia as well, probably because of the autoimmune coexisting factors like pernicious anemia and the autoimmune gastritis. These are the things that coexist in such setting. And also in severe hypothyroidism, we can even see normocytic anemia because of the direct effect on the bone marrow, erythropoietin suppression. So one important clue is that in hypothyroidism, since all these can coexist, you could get a normocytic anemia with a mixed population of microcytes macrocyte as well as a normocytic anemia. So one important clue is RDW, the red cell distribution width. We know that RDW is a good clue to differentiate microcytic hyperchronic anemia due to iron deficiency from beta thalassemia, where normal RDW could be seen a beta thalassemia trait, while iron deficiency we could see a high RDW. In hypothyroidism, it's an early marker. RDW, elevated RDW is an early marker, and it could give you a clue if you are dealing a refractory anemia with a normocytic picture. Increase RDW and the background of hypothyroidism is you should consider this as an important cause, and hypothyroidism contributing to anemia in good extent. And another important point I will discuss in this particular setting is a case I encountered. He had a vascular toxic snake bite, viper envenomation, and he presented to nephrology. He has a diffuse cortical necrosis related renal failure, and he was going for hemodialysis because of NCR renal disease. Then shrewd nephrologist actually found that his cortisol is low, and previously he was not evaluated for low cortisol, and this patient has been initiated on cortisol, and his creatinine actually came down. And then we encountered a case of refractory anemia. Patient was already on erythropoietin iron supplementation, but his hemoglobin was remaining at 7. And then we found that because of this panhypopituitarism, which was untreated for so many years, and we diagnosed panhypopituitarism and treated with testosterone, his hemoglobin came back to normal for the first time. So he had a refractory anemia even with erythropoietin and iron, supplementation of iron, and he was on long-term follow-up with nephrologist. But until we correct the testosterone deficiency, his anemia was refractory. So
Okay, right.
this was a good scenario
Right.
to intervene.
Right. So already we have talked about hypothyroidism causing anemia. So can I ask Vaishali is about hyperthyroidism and anemia? Does hyperthyroidism, can it be associated with anemia?
Yes, sir. So definitely hyperthyroidism also has anemia. Commonly, we see deficiency related anemia and a normocytic anemia. So we could get iron deficiency because of rapid turnover and rapid utilization of the nutrients. We can get associated pernicious anemia with B12 deficiency. We can get high RBC turnover occurring because of the rapid metabolism, and that can actually hasten the lifespan of the RBCs and cause anemia because it cannot cope up with the essential nutrients. And then you have the autoimmune conditions, like you can get autoimmune hemolytic anemias, you can get deficiency induced, and of course the normocytic normochromic anemia, because we know that thyroid hormone is essential for RBC production and erythropoiesis as such. So very rarely you can also get high RBC count. So you can get a high erythropoietin production and erythropoiesis also, but commonly what we see is anemia. And if it's associated with menstrual disorders, again, that also can come with iron deficiency and blood loss anemias.
Yeah, but of course, typically hyperthyroidism is not associated with anemia, but could be. So probably if we see a low hemoglobin, hyperthyroidism possibly is not high on the list of our suspicion, is what
Yes.
you also are trying to say. Yeah. So can I ask Shahana? So in unexplained anemia, you've done all the various tests, the ferrokinetics, B12, and all, which didn't throw out an answer. Can we think of hyperparathyroidism? Does it also cause hyperparathyroidism is to do with high calcium in blood and all that? But can it also cause anemia? Please unmute yourself. Unmute yourself.
So hyperthyroidism, I think there are different case series have reported different prevalences. I think between 15 to 50% the prevalences of anemia has been reported. So we can say, although it's not the very common manifestations, but anemia can be seen. Now, again, this can be due to several reasons. Multifactorial etiology is described. So first and foremost, the PTH has a causes some kind of erythropoietin resistance because there are the PTH receptors. The PTH directly acts on the bone marrows where there is receptors, and this can inhibit the action of erythropoietin and thus suppress the production of RBCs. So at the level of the marrow itself, and then we know that the primary hyperparathyroidism is associated with metabolic bone disease as well. And then in severe cases, you can have a condition called as Brown's tumor, which is also called as osteoitic fibrosis cystica, where you have kind of bone marrow involvement and also fibrosis. You can have focal fibrosis with cystic changes. Now, this also this involvement of marrow could also contribute to anemia. And then, of course, another common reason, just like we state any other diseases, that is anemia of chronic disease. So the iron can be trapped in the storage site and may not be available for utilization. And so thus, just like in any other inflammatory state, we can get anemia of chronic disease. And then, of course, in patients with complicated hyperpara, like if they have pancreatitis, of course, that's malabsorption and anemia, or if they have renal dysfunctions, and then they can also have anemia. So in general, the picture is more of a normocytic normochromic anemia with a low retic count. So the anemia, hyperparathyroidism can also manifest as anemia. And once the hyperparathyroidism is corrected, there might be slow recovery of anemia also is being seen.
Right. So there can be recovery also. Yeah. Okay. Reversible cause of anemia. Right. So let's come back to Dr. Ankur, and let's have a case scenario. A lady, 60-year-old, type 2 diabetes of some duration, has a hemoglobin about 10. So shall we just pass it as normal, or shall we think of other things? If so, what would be the issues that could be causing a slightly low hemoglobin in someone with diabetes of some duration?
Look, specifically, if it is a female diabetic patient, female patient with a hemoglobin of 10, I would really like to see at least a few things. Number one, need to rule out CKD, because we know that in diabetes, CKD is quite common, and CKD essentially have some bit of anemia because of the renal tubular dysfunction and erythropoietin problem. The second thing I would like to see whether there is any menstrual problem which is
Yeah,
leading.
this is a 60-year-old lady.
So sometimes patient might had history of disuterine bleeding DUBs that can lead to anemia, or malabsorptions. Although celiac disease is quite rare in such a later age, but yes, sometimes we do find elderly patient diagnosed celiac disease in quite late age, and only workup of anemia starts for celiac disease. Then, of course, the diet which Indian patients are taking, we know that majority of being vegetarian patients, and for vegetarian, the dietary sources of irons are not quite rich. So many times, and it's not surprising to see a hemoglobin of 10 in our rural female population because of the dietary issues. So these common factors has to be ruled out. Then, of course, being a female, hypothyroidism or thyroid disorders has to be ruled out, whether it can lead to anemia. And as Dr. Gangadhar was telling, need to just simply see what kind of anemia it is, whether it is microcytic hypochromic anemia, whether it is normochromic normocytic anemia, or whether it is macrocytic megaloblastic anemia. And then we can do the basic workup. But merely having only 10 hemoglobin and just passing it away, I don't think it is a good idea. We need to have some basic workup as far as this 10 HB is concerned.
Now, we all use metformin, and we are aware that metformin may be associated with B12 deficiency. So, do you see anemia along with the B12 deficiency that may be associated with metformin use?
Yeah, that would be a megaloblastic or macrocytic anemia if it is associated with metformin use.
Right. So we have a couple of questions. Let's get to a question from Dr. Sandeep from Jaipur. When a patient is started on thyroxine for severe hypothyroidism often notice a mild rise in serum creatinine. Is this expected, or should I be worried about intrinsic renal damage? Maybe Vaishali?
There is a definite elevation in serum creatinine in patients with hypothyroidism if it's left untreated, because it's related to the normal functioning. All the processes in the body are slowed down with hypothyroidism. So the urea and creatinine turnover also in the blood is decreased. So that is why you do get a high rise in the serum creatinine, which normalizes as soon as there is a euthyroid state achieved. So I think you need not worry over here in this situation. You try and correct the hypothyroidism first. In case you are suspecting that there is isolated other renal dysfunction, especially autoimmune conditions like SLE can have both. So you can have renal dysfunction as well as the hypothyroidism. So it's better to investigate earlier in such situations where you are suspecting an additional cause. Otherwise, you can wait for the normalization with a normalizing of TSH level.
Yeah, exactly, sure. And I think rather than treatment of hypothyroidism leading to increase in creatinine, we see just the opposite. There may be some rise initially, which may normalize with treatment of hypothyroidism.
Yeah.
And we go on to maybe Dr. Pratosh for the next question. It is set by Dr. Amit from Pune.
Yeah.
Can a routine complete blood count showing mild unexplained eosinophilia be a clue to adrenal insufficiency? In other words, if you can also open up and tell us if the differential count, we talked about hemoglobin, RBC indices. So can the differential count also give us a clue to adrenal or sorry, of endocrine problems?
Yeah, differential leukocyte count, especially in the setting of endocrine context, we always consider eosinophilia being a clue to adrenal dysfunction. But you have to always collaborate the other clinical evidences. What are the symptoms of the patient? And generally, if there is no other cause for that, because adrenal insufficiency, because loss of cortisol actually removes the inhibition of eosinophil production, you will get eosinophilia. It could not be very high eosinophilia to the tune of 5 to 6%, that in an unexplained illness with coexisting features, symptoms, hyponatremia, and hypertension and pigmentation, in the setting, you could always think about adrenal insufficiency. Regarding other causes of that could give you a clue for endocrine disorders, one thing is neutrophilia. Neutrophilia, again, in glucocorticoid excess, like Cushing syndrome and exogenous steroid, you could see there could be an increase in neutrophil count because of that. Leukocytosis due to neutrophilia, you could see it often accompanied by lymphopenia and eosinopenia. These are clue. If you are seeing the coexisting neutrophilia with the lymphopenia and eosinopenia with a history of steroid or Cushingoid features, that could be a clue that we are dealing with something endocrine cause for that. Another scenario, you could see lymphocytosis in autoimmune endocrine disorders, and even Addison's, sometimes you could get lymphocytosis. And Graves, you could see even leukopenia and lymphocytosis. Leukopenia in active Graves because of bone marrow suppression can happen with this particular illness, you could see. And but most important thing, we often encounter and see the CBZ in endocrine practices during antithyroid drug treatment, where we could always look for agranulocytosis and absolute neutrophil count in CBC to whether the drug is producing any damage to our patient. And it's one important cause, although it's rare, one should always look for this in clinical practice. And another probable differential count clue that will give us some importance in endocrine practice is neutrophil to lymphocyte ratio, NLR. NLR is an important marker of chronic inflammation, and the values to the cutoff of 2 to 2.5 to 3 above is a indicator of chronic inflammation, and it could give you the clues regarding whether metabolic syndrome, the associated complications like diabetic nephropathy and type 2 diabetes. If the ratio is high, that indicates there is significant chronic inflammation underlying in that particular patient. So it's a marker of diabetic nephropathy. MSLD, it's a marker of increased hepatic fibrosis. So there are multiple ways by which NLR could help you in practice. So it's a very simple test, but just looking at the NLR, you could see this high inflammation is there in this patient, and you should be aggressive in looking for other complications.
Right. So NLR could be a marker of insulin resistance as well. Right.
Yeah.
And so we keep need to keep our eyes open when we even look at these simple blood tests.
Yeah.
So a quick one from Dr. Shahana. So this is Dr. Kavita from Hyderabad. So what her question is, if a diabetic patient shows a unexplained drop in LDL and total cholesterol, would that prompt her to screen for thyrotoxicosis?
Yeah, just be purely based on the lipid profile pattern, we would generally not look in that direction. Of course, the clinical symptoms will be much more obvious if there is thyrotoxicosis. Although you would, I mean, in patients with thyrotoxicosis, you would see a reduction in LDL cholesterol. But if I have a patient with diabetes, say has low lean BMI, I mean lean body habitus, and has low cholesterol, I would actually look for pancreatic diabetes and evaluate in that directions. Thyrotoxicosis was also associated. Of course, these patients will have clinical manifestations of thyrotoxicosis.
Right. Yeah. So in order to have low cholesterol, low LDL because of thyrotoxicosis, it's unlikely to be just a subclinical condition. Right. So can I come to Vaishali once more? This is about, of course, a vast issue of hypokalemia. Of course, it may take hours to discuss all the nitty-gritties about evaluation and management of people with hypokalemia, but can we have some sort of guidelines as to how to approach someone who's been found to have low potassium? Maybe we can try and bundle them into those who have got normal blood pressure versus those who have got high blood pressure, or whichever way you want to look at it.
Yeah, just to simplify the approach, what I feel is that first is you need to confirm whether it's really a hypokalemia, because most of the times it may just be a lab error, and it may not actually coincide with the ECG and the clinical symptoms. But if you have a circumstance in
Is
which
hypokalemia a
proven,
sort of
yes,
common lab error?
yeah.
Hypokalemia?
It is a common lab error, because we
Okay.
usually go by the VBG reports where they would have
Okay.
some erroneous.
Mhm.
So in our emergencies,
Right.
I've seen many a times that the ECG never coincides. Patient doesn't have
Yeah.
any reason for hypokalemia, but they would have that kind of a report. So we
Yeah.
usually go
On
by
a
the
VBG
lab
report.
confirmation.
Yeah.
But nevertheless, having said that, if you have confirmed that there is hypokalemia, you classify it as severity wise also. I have, in terms of treatment intensity, that gives us a guidance for a clinician. Suppose it's severe, it's better to replace it earlier than to look into the causes first. And if you have a
So
mild one,
what is severe then?
yeah, so severe would be less than 2.5, which is we're having a lot of ECG changes, hypokalemic paralysis, and other features which are life-threatening. So that would require immediate treatment.
True.
Then you go into the causes. So causes-wise, if you have to classify as a clinician, I would look into whether the patient is losing potassium. That's why he's getting hypokalemia. So the losses would be mainly from the GIT or from the kidney. So the GIT losses are usually obvious. So they would have some loose motions or dehydration or some element to point out. Especially the BP is low, the patient has GI symptoms, then it usually gives me a clinical suspicion that there could be a GI loss. But when I'm talking about renal loss, then comes the role of an endocrine. So renal loss, I look it into two ways. One is whether the patient is having a high BP or a low BP. So, or a normal BP. So if the patient has a high blood pressure, it points more towards the hyperaldosteronism, mainly the primary aldosteronism, because especially in a setting where there is metabolic alkalosis. So alkalosis, hypertension, and hypokalemia. I think that triad proves the common cons syndrome triad, which we see. And then you also look into causes for secondary hyperaldosteronism. And if you don't find any such abnormality in both these elements, then you look for the renal causes. So you look for the hypereninemic hyperaldosteronism status. So that could be, so renal causes are also very common. Commonly, which we come across in our own practice is renal tubular acidosis, which is very common in my practice. Second commonest is the Cons syndrome, and then Cons, of course, you suspect when you have hypertension with no signs of fluid overload, and still the patient is having a evidence of metabolic alkalosis, and it's mainly due to the shift of potassium rather than a loss. You can say that it's more the alkalosis is causing that shift. I also come across a lot of patients who take a lot of Lycoris. Lycoris is a very common drug which is used in Ayurvedic medicine. And I've seen that people who consume more than a month of Lycoris, they too come with such features of uncorrectable hypokalemia. And I think there you need a strong suspicion of the drug history. Drugs are very common causes. So especially the loop diuretics, the thiazide diuretics, these are very commonly, even for that matter, digoxin and cardiac drugs are known to cause. So I think we need to look into the potassium loss. If the potassium is higher in the urine, and you have this triad, I think you go more into the renal side, you look at the adrenal side, and then you get investigated further. So I think these are the pointers clinically which may help in classifying. So you need to do a acid-base evaluation first, you need to do a blood pressure evaluation, and you need to try and look in further. It's a transitional shift, especially in thyrotoxicosis patients where you get a hypokalemic periodic paralysis. It's mainly the shift of the potassium. It's not the loss of the potassium. It's more of the
But
shift.
how do you establish that, whether it's a
Yeah,
shift or
so it's a scenario in which we diagnose it. So patient has thyrotoxicosis clinically and he has come with a forelimb weakness with hypokalemia, then we take it for granted that it is a shift, not the loss. There is no obvious loss in the urine. The urinary potassium is usually normal or less in these patients. So they would not have, of course, thyrotoxicosis can also complicate a RTA. So they can come with a renal tubular acidosis in addition. So we do come across patients who have multiple disorders, but I
yeah,
think that needs to be seen judiciously. So I think overall, I would put this at the simple approach would be you see the BP, you see the ABG, you see the clinical condition and the scenario in which he presents, you see all the drugs because the list of drugs that the patient is being taking in the past with more of the over-the-counter, especially steroids. So that also needs to be looked into in depth. So I think this would give us a fair idea about the cause. Even
right.
DK
And
is a very common cause. I forgot DK. DK is a
okay,
very common cause for urinary potassium loss. So that is one thing we need to see.
yeah, and of course, diuretics we also need to talk about, and remember that at least drugs like chlorthalidone, even if it's been stopped, even a week, at least week 10 days back, may still continue to cause hypokalemia. And you just mentioned that loop diuretics ahead of thiazide diuretics in terms of the propensity to cause hypokalemia. Do you
No,
think that loop diuretics?
yeah,
Sorry,
I would say that thiazides are more notorious in this aspect, but
right,
loop diuretics are more into dehydration, and so
yeah,
that is why I prefer
right,
them for SSIDH rather than
right,
for these conditions.
right. So we come back to Dr. Ankur, and so someone has got an ECG done. So can we diagnose or suspect hyperkalemia, because we are on the issue of potassium? So hyperkalemia from ECG, and then quickly, what could be the possible causes? How do we evaluate?
Yeah, I'm glad that our MD days are back. So look, of course, with the mild hyperkalemia, that is potassium around 5.5 to 6.5, we can expect a increase in the amplitude of the T wave, and we call it as a tall tented T wave. So initially, the tenting of the T wave occurs. Then 7.5 onwards, you may expect lowering of the amplitude of the P wave or flattening of the P wave. when the hyperkalemia is more severe, especially if potassiums are more than 7.5, we can expect the QRS to be start widening, and at very severe hyperkalemia, say of potassium more than 8.5 or 9, you may expect the classical sine wave pattern which we used to remember for our PG questions. So these are the basically ECG changes which we can expect for hyperkalemia.
Yeah, and so if you find hyperkalemia, what are the common causes that you would think about and evaluate for?
Look, as you earlier told that hypokalemia is a quite frequently, so is a hyperkalemia. So first and the foremost, we have to rule out whether we are dealing with the true hyperkalemia or this is pseudo hyperkalemia. So we know that the reason of pseudo hypokalemia are of course hemolysis because of the mechanical force, or it could be because of the severe leukocytosis, in which hyperkalemia can be there because of the leukocytosis per se, or sometimes very using of very tight tourniquet while taking samples could also realize there are no drug causes. Then of course the first and the foremost thing one should do is try to do renal functions, because we know that renal deficiency, renal insufficiency or CKD or even AKI patients may develop hyperkalemia very soon. So we have to do these blood work, and then if everything is fine, then you can do what you can do is you can try to see whether a patient is having more excretion of potassium through the urine. So one could do spot urine potassium, and if spot urine potassium is say more than 20, then it basically means that patient is losing potassium through the urine, and then you have to do the workup. And there are one, two endocrine causes also. One is, of course, adrenal insufficiency. So we know that adrenal insufficiency patients may have hyperkalemia because of the low cortisol value. So that has to be seen whether it is causing hyperkalemia or not.
Right. So number of issues, but of course, drugs, kidney impairment, and adrenocortical insufficiency, or maybe much more rarely even hyporeninemic hypoaldosteronism,
Yes.
may cause
Especially in diabetic
hyper
patients.
in diabetic patient. Right. So we have a question from Dr. Rajesh from Chennai. So when a patient with poorly controlled type 2 diabetes who has persistently high platelets, yeah, true, we didn't talk about platelets, we talked about WBCs, RBCs, but no sign of infection. Should it be viewed as chronic inflammation, or should it be a clue to something like Cushing syndrome? Who would like to take that? Dr. Shahana?
Sure, sir. So, platelets, actually, one of the common thing we should think of is like associated B12 deficiency. In B12 deficiency, we can, other than anemia, you can also have some amount of thrombocytosis. So you might get an elevated platelet count. I wouldn't think of Cushing's in that particular patient. But again, iron deficiency can also have thrombocytosis. So I would look more of a systemic kind of condition than an endocrine etiology in that particular patient in type 2 diabetes.
The thrombocytosis in type 2 diabetes. Can I?
Sure.
Yes, of course.
Yes, sir. Regarding thrombocytosis, always think about a chronic infection, underlying infection. You could get a reactive thrombocytosis. So especially pyelonephritis or something like that could be hidden. And recently I encountered a patient who had a refractory thrombocytosis, anemia, and leukocytosis. This is a family with VHL, two young girls, and they actually had thrombocytosis as a paraneoplastic manifestation due to high interleukin 6 secretion. So even that could be there, although it's very not a common thing. But that thrombocytosis was the clue for going behind interleukin 6. So generally,
so infection, yes, of course, but Dr. Rajesh has already mentioned that there's no evidence of infection. So maybe these are the other conditions. So we keep to you, Dr. Pradosh. So we all now have packages, tests done multiple tests done at relatively low cost, and people go for it. And so this gentleman, 65-year-old gentleman, was found to have a calcium of, let's say, 11.2. The upper limit of normal was, say, 10.4 or 10.5. So elevated, not grossly elevated, calcium as part of routine checkup. So what do you do now?
Yeah. The mild hypercalcemia, always confirm whether it is a true hypercalcemia we are dealing with. Always check the albumin and go for the corrected calcium levels. Ionized calcium can be done. And in case of mild 10 to 11 kind of hypercalcemia, I will always reconfirm from our lab, because sometimes I have seen calcium of 11 from outside. In our lab, it turns out to be 14. So because of the analyzer related issues, it could be like that. And obviously with the mild hypercalcemia also, we need to exclude a early primary hyperparathyroidism. That's one concern we often have to deal with. So the next basic step could be to go for the other tests like phosphate, alkaline phosphatase, and vitamin D along with PTH. So most important test will be PTH. If the PTH is normal or elevated in the setting of a mildly elevated calcium, we could be dealing with a early primary hyperparathyroidism, or it could be a familial hypocalcemic, hypocalciuric hypercalcemia like scenario, or lithium related. These are the common causes where you could see a mildly elevated PTH or normal PTH with calcium of 10 to 11. And if PTH is suppressed, then we could think about the neoplastic or other causes like granulomatous causes. But with 10 to 11 calcium, it's not that very common. And but generally, the neoplastic causes, we see calcium towards higher side than this. But in an early phase, you could it could be a marker of even paraneoplastic calcium elevation.
Absolutely, and of course, as you said, primary hyperparathyroidism is still a possibility. So, looking at the phosphate along with the calcium can also help. Cannot exactly establish, right? So we have some more questions here. So so Dr. Jay from Ahmedabad. So thanks for bringing out the maybe the gaps in sort of the questions that we are sort of trying to get answers to. So Dr. Jay's question is, in young obese patients with high uric acid. So that's uric acid we did talk about. High uric acid, and that's something that every lab does. Every patient goes and wants to get a uric acid done because he or she has got aches and pains. So uric acid is very commonly done, but no history of gout. Does treating underlying insulin resistance help lower uric acid level practically? Dr. Shahana?
Yes, so hyperuricemia is definitely a component of metabolic syndrome. And when we are, I think most importantly is we'll have to look at the clinical symptomatology, what is patient is presenting with. Many times patients come with generalized body ache and they attribute it to high uric acid, but we'll have to look at the symptomatology of how the gout presents and whether it is fitting into that. If that is not fitting and we are just finding a mildly elevated uric acid in the presence of other components of metabolic syndrome, then addressing the obesity and insulin resistance would take care of hyperuricemia in many of these cases. So we need to look at the clinical manifestation in terms of the arthritis presentations or renal calculi. Only then we need to make a decision of treatment, and of course a follow-up would be needed.
Right, yeah. So treating the underlying insulin resistance could help in getting the uric acid down. Great. So we stick to maybe electrolytes and talk about sodium. And Dr. Jana, so this is an elderly gentleman admitted with hyperglycemic hyperosmolar syndrome with very high glucose levels, 600, and sodium is 125, 128, let us say. So how do you approach?
Yeah. So in this condition, actually, this patient has presented with hyperglycemia. So when you have severe hyperglycemia, that is, of course, you already mentioned the diagnosis of HHS. So when there is severe hyperglycemia, the hyponatremia, what we get is more of a dilutional thing because of the high glucose. There is a shift from the fluids from the intracellular compartment to the intravascular component. So that causes a spuriously low sodium. So in such conditions, we have to correct the sodium so that if for every 100 millimole, for 100 milli equivalent, for every 100 milligram per deciliter increase in the glucose, they need to add 1.6 correction of sodium. So if you're saying 600, then this correction is for up to say 400, and beyond 400 we have to multiply it by 2.4. So for this particular patient, so 300 into 1.6, you will get around 4.8, and then beyond another 400 to 600, maybe 2.4 into 2, so again 4.8. So you will have to add an addition of 9.6 to the actual sodium. So if the sodium is around 128, then the correction would come around I think 137. Well, yeah, 137 or 138. So that would come actually in the normal range. So the sodium actually is normal. But then this is a patient which has come with hyperglycemic hyperosmolar state. So in this condition, of course, fluid resuscitation, this patient would have significant fluid loss as well. Many of the patients actually, when we even correct, the sodium is still lower side, not very low, but it might be lower side. So we'll, of course, and then dehydration is a very important component of this entity. So fluid resuscitation is the most important aspect in this patient with HSS, and then of course insulin infusion. The electrolytes which we need to focus when we are correcting insulin, of course, is the potassium, and then of course many of times there is often precipitating factor which has to be treated.
Right, exactly. So we can have so-called sort of pseudo hyponatremia, especially in the context of a number of issues, including very high glucose levels. So let's come to more common situations where we see low sodium, something known as SIADH, if Dr. Vaishali would enlighten us as to how to diagnose this condition and how to treat it.
So it's the commonest endocrine emergency that we come across in the IPD setting, and more common in critical care, in oncology, and in infections. And the diagnosis is mainly with hyponatremia and hypoosmolality in a setting where you have a high urinary osmolality relatively. So the patient usually does not have any edema, no ascites, no fluid overload, and the blood pressure is usually normal or slightly on the higher side. And all these situations where you get a low sodium, but the osmolality continues to remain low. Low in the sense less than 275 at least. And if the urinary osmolality in such a setting is more than 100, it is a high osmolar urine, and that confirms the diagnosis of SIDH. Of course, we have to rule out three important conditions. One is you should rule out hypothyroidism, adrenal insufficiency, and renal dysfunction before you label the patient as SIDH. Secondly, you need to look out for the the primary cause that is leading to SIDH. So there should be some underlying cause. Commonly, it's drug-induced or infection-induced, malignancy-induced, or there could be certain hormonal deficiencies which can present like this, or in stroke patients, cerebrovascular accident patients, and cardiac patients, you could get this in acute critical conditions, but you have to rule out fluid overload and other causes of hyponatremia which are related to organ dysfunction.
Right. And in terms of management, what do you do?
Yes, so the
Let's say on a
yes, sir,
yeah,
please.
please. No, on a not necessarily as an IPD inpatient, but as a chronic patient. If you have diagnosed SIDH, what do you do?
Yes, so in the acute setting, you would need a 3% NS in the patient is critically ill or drowsy, confused, seizures, or in a situation where you need to rapidly correct the sodium. But one needs to be careful when you're correcting sodium. You don't correct more than 8 to 10 milliequivalents in a 24 hours period. So you go very slow with 3% NS. The decision is made based on the criticality of the situation. As far as the chronic condition is considered, The chronic SIDH is very common. It's common in the elderly with water intoxication. They tend to drink a lot of water and retain that. And then you find that they go into repeated episodes of recurring hyponatremia. Commonly, which I see in practice, is a lot of hiccups and nausea and vomiting coming, and decrease in appetite. And sometimes they would come with psychological disturbances like depression and dementia too. So basically, this is what I see commonly in practice. But if you find a low sodium and low osmolarity in this situation, you have diagnosed it. The first and foremost is restricting their free water intake. Second important is loop diuretics are Lasix especially is known to be very useful for excretion of free water as compared to the salt. And third important is then use of tolvaptan. So the ADH receptor antagonists, which can help in improving the osmolality over a period of time. And then you can gradually maintain these patients on a proper fluid balance. But one needs to understand that it's a recurring problem. So it doesn't cure itself. So you need to keep these people under observation, especially when they get ill due to some reason. We saw that in COVID. So a lot of SIDH patients who were stable otherwise in COVID went into repeated hyponatremia, and so the infection is known to offset their balance of sodium and electrolytes. So I think we need to pay attention to these at a repeated follow-up. So they need a chronic management.
Right. So when you find on a chronic basis low sodium, so do you look at the urinary sodium loss?
Actually, it confirms the diagnosis. Repeated hyponatremia with a hypoosmolality with a patient who doesn't have any other obvious causes and is not edematous is enough for diagnosis. But if you want to still confirm it, you can do a urinary sodium. I don't do it in my practice. So urinary sodium and osmolality can be done for practical purposes to prove your diagnosis. But I think most of our patients just require a simple test of serum sodium and osmolality. That's enough. Our target is
Okay.
to normalize the osmolality, not the sodium alone. So if I'm treating chronic SIDH, I'm not just treating the sodium. I'm trying to get the osmolality to a range between the 275 to 295 so that these people do not have that intoxication, because sodium recovers very early, but osmolality may take 3 to 6 months to stabilize into a normal range.
And when you mean you want to estimate the osmolality, it's not uh, calculated osmolality. You mean freezing point depression proper osmometer, or how do you do that?
Actually, our lab gives, so I don't really calculate. So I don't do the job, but our labs give the direct value. So
Okay.
I've not really thought of calculating it. But yes, one can calculate it also with a formula.
Right. So, Dr. Pratush is the calcium
Yeah.
man. So, Dr. Kiran from Vizag asks you, uh, he uh, he often sees young patients with serum calcium sitting at upper limit of normal,
Yeah.
10.2, 10.3. So, should I pass this off as normal hydration status as just related to hydration status? Or should it trigger a baseline PTH workup, or should it require a referral to Dr. Pratush?
Yeah, ideally, you should repeat the reading, and if it is still on that range, it's always better to work up. You could pick up a disease process early so that you could prevent advanced disease in the later life. Although we need to work up a bit in that scenario with PTH, alkaline phosphatase, phosphorus level, and vitamin D, and even sometimes we need to measure the urine calcium creatinine clearance as well. These might be needed in such scenario, especially young patient. It could be the reasons as we already discussed. It could be an early primary hyperparathyroidism. It could be a familial hypocalciuric hypercalcium, which is very common. There are a lot of patients with that range of calcium are turning out to be FHH in practice. So at least we could give them reassurance, and we could avoid over investigation, and better to refer to a endocrinologist in that setting, because there are many uncommon causes for mild hypercalcemia as well.
Right. The next question is for Dr. Shahana. So this is Dr. Shankar from Bangalore. Many patients with obesity in my clinic has mildly elevated ALT, AST. What is your threshold to label it as standard fatty liver versus ordering an extensive liver workup? So what would you do?
Yeah. So, of course, whenever we come across obesity and slightly elevated liver enzymes, the first diagnosis would be MSLD. But again, so we need, but then of course we need to look of other causes for raised liver enzymes as well. So the alcohol history, the screening for viral hepatitis, those things has to be done, and we probably, and also we'll have to look at the liver profile of which enzymes is elevated, what's the bilirubin, whether it is just ALT elevated or it's more of a cholestatic picture. So that also has to be seen, and imaging has to be done. But in general, whenever we come across an obese patient or type 2 diabetes, we know the prevalence of MSLD is as high as 60 to 70% in these patients. So that would point towards MSLD. And then, of course, for further risk stratification, we now have the fibro scan, which can help us to understand what is the stage of the disease. And then subsequently, depending on that, we need to address the condition.
So would you be happier if the ALT were higher or the AST is higher, or does it make a difference in our understanding?
So if you're talking about the MSLD, obesity, and most of the other, or say alcohol related, it's sorry, except for the alcohol, most of the times it is ALT, which is more elevated than AST. I think with the alcohol, AST is described, so that's the difference.
Right.
But then I would be concerned with both, yes.
Yeah, that's true. But even with AMSLD, I mean, if you have more of an AST than ALT elevation, to me, that's more an indicator of progression towards
So,
fibrosis. So maybe a FIB4 index or something would give us slightly better nuanced idea as to what to do, whether to do a fibroscan or not, right? So we can continue and let's say uh, have whom should we have? Dr. Pratosh. So about HbA1c, now everyone, of course, advises HbA1c for at least evaluation of control of metabolic status in diabetes, maybe even for diagnosis of diabetes. So for someone with diabetes, type 2 diabetes of some standing, A1C of 5.8%. So just looking at the A1C 5.8%, are you happy that?
Yeah, HbA1c 5.8 always may not indicate a good glycemic control. I always look at the other glycemic parameters like fasting glucose, postprandial glucose. If we have done a CGM, even CGM metrics, if you have GMI, we can look into GMI, which is the indirect measure of HbA1c. If these are not correlating, always think about something with the abnormal with the hemoglobin. So generally, you could get a low HbA1c in the setting of abnormal hemoglobins like hemoglobinopathies, and commonly it could be due to sickle cell disease. Even variants like HBC and HBE could produce a low hemoglobin A1c, and most of the times that if you are doing with a Biorad HPLC analyzer, the analyzer itself give you a clue. There is interference with HB variant. You could likely to be look into this report with a suspicion. They often tag that in many of the labs. So I have seen even HbA1c of 58%. That is due to other spectrum in an otherwise controlled patient with HbA1c 58%, and it could be due to other HP variant like GRAS or vein. These are the rare variants that so this hemoglobin because it's a basically they are doing it by HPLC method. So these analyses all interference can happen with the hemoglobin variants. Even with a normal hemoglobin, you could have variants. So always, even the patient has got a normal hemoglobin, you need to work up for that hemoglobin variance in that setting. So always correlate with the glycemic parameters. If it is not correlating, always think about HB variants or anemia. Even iron deficiency anemias, it can actually increase the HbA1c levels, and anemias can have different kind of impact on HbA1c. Always think about that.
Yes, and of course, if you have blood loss, if you've got hemolysis, then also you can have falsely low A1C
Yes,
value.
yeah, again, the medical conditions like hemolysis and
Right.
blood loss.
And Now, we talked about anemia initially, Dr. Shahana. So, can we now talk about high hemoglobin values? Someone young person,
Yeah.
young gentleman has hemoglobin of 17.
So, if you're talking about an endocrine setting, when we see elevated hemoglobin, I think mostly we see in conditions like obesity with severe obstructive sleep apnea, or the most common cause again would be smoking, which we have to look for. This is the common scenario which we would encounter, and if other endocrine disorders I have to talk about, I think those are rare conditions, like for example in conditions where you have like for example in pheochromocytomas we can have a tendency of having polycythemia. But in general, when we come across high hemoglobin, I think first and foremost, first of all, the criteria of polycythemia is met, like above 16.5 in men and above 16 in women would be the definition of polycythemia. And then of course we need to first rule out conditions like smoking, and then high altitude, and then obstructive sleep apnea, which and then any lung conditions have to be seen. I mean, these are the most common scenarios. But then of course then also look at the other clinical presentations and try to make a whether we can look for any secondary causes. Primary causes, primary polycythemia, generally we see in elderly populations as mild proliferative disorders. Of course, then you would do an erythropoietin. If you know that if erythropoietin is low, then of course we would then do a JAK mutations and other workup for polycythemia vera.
Right, and of course, in the endocrinologist clinic, those who have been on testosterone for some
Yes,
duration,
yes,
that
yeah.
may be a cause for
Yeah.
elevated, yeah. Right, so we have Dr. Sanjay from Delhi about patient presenting with mild unexplained hypophosphatemia, but calcium is perfectly normal. When should I suspect early vitamin D deficiency versus a hidden normocalcemic hyperparathyroidism? Core endocrinologist question. Anyone can take up. Ankur, you've been silent for some time.
Yeah. So I think if calcium is normal and only phosphorus is low, then of course one of the causes could be vitamin D deficiency. But usually in normocalcemic hyperparathyroidism, uh, you may get higher urinary calcium, number one, or you may have assisted osteoporosis with the normocalcemic hyperpara. Then only you go for the treatment. I will really like to see whether this patient is having hypophosphatemic rickets, because of the XLH, that is X-linked hypophosphatemic rickets, which is more common in pediatric population or younger adults, and even in elderly or even in adulthood we have tumor associated osteomalacia, which may present with hypophosphatemia. So if phosphorus is really low, then I will really look out to at least rule out these three conditions. And calcium as well as phosphorus are very notorious tests. So you always need to repeat the test one again before going for a single reading of calcium or even phosphorus.
Yes, uh, I suppose that covers it. So we all are sort of aware of the need to screen for dyslipidemia, treat dyslipidemia. So if we find someone with dyslipidemia in an endocrinologist clinic, uh, what are the checklists that we go through uh, before we go on to just writing a statin? Once again, Dr. Gehlot.
Yeah, look, as we know, the most common cause, most common endocrine disorder is thyroid disorders. So, just looking at a patient with dyslipidemia, we have to rule out, we have to see what kind of thyroid profile it is. Suppose if patient is having relatively normal triglyceride but very high LDL levels, so these kind of lipid abnormality is very common in hypothyroidism, where we see the LDL levels are quite high, while the total cholesterol may be elevated, but Occasionally the triglyceride levels are elevated, mostly they are normal. So if this kind of thyroid profile we are seeing, then of course we have to rule out hypothyroidism as a cause of dyslipidemia. And now other kind of dyslipidemia in which the LDL levels are relatively normal, but triglycerides are high. So that may be usually found in patient with type 2 diabetes or uncontrolled type 2 diabetes. If the diabetes is very much uncontrolled and this and hyperglycemia is quite severe, then you might find very high triglyceride levels also. So severe hypertriglyceridemia can be found in patients with very uncontrolled diabetes, either type 2 or even type 1. Then occasionally we can think of other endocrine disorders like Cushing's disease. We can have dyslipidemia in Cushing's disease also, where the LDL and triglyceride levels both are increased, while the total cholesterol is also increased. Then we have dyslipidemia in rare syndromes like growth hormone deficiency also, where you will have high LDL levels and high triglyceride levels. So these common endocrine conditions which we have to look, and the first and the foremost we have to see whether the sample has been taken in true fasting or not, because it is quite common that patients do get lipid profile in non-fasting state. And sometimes, and we know that even with a very small meal or even with a tea, the triglyceride levels can really go up. So we have to see whether it is a true fasting lipid profile or not.
So can I get a quick comment from all the panelists, the others now, uh, about the importance of fasting for doing a lipid test? Pratosh?
Uh, in practice, we often labs recommend to do fasting, but there are some shift in consensus regarding um, doing lipid profile in non-fasting condition, because it's easier to do. Only thing is that you have to take into consideration of the fact that triglyceride could be high, as Dr. Ankur already mentioned, but
Yeah.
LDL may not have much impact with the meal. So if you are really looking to the LDL levels, and then it could be still useful if the patient has done a random lipid profile. And other important issues that if the patient has hypertriglyceridemia, sometimes after meal, it could lead to significant lipemic sample if the triglyceride levels are high, and it can actually lead to a lot of assay-related issues. It can give you a spuriously high cholesterol. So that is another issue you need to consider, especially even good analyzers can have cross reactivity. It actually interfere with the analyzer method, photometry assays, and high triglyceride could actually give you a high LDL and total cholesterol reading. And recently we had a case scenario like that. That is why probably it's better to do the test in fasting level. But you could analyze the report given to you by a non-fasting sample patient. Inadvertently done that, we could analyze that. But if you have any queries, it's better to do it in fasting.
Good. Would others have other opinions? Shahana, Vaishali?
Yeah, I think I completely agree with Dr. Pratosh. I think the main concern will be TG evaluation. But if somebody has come with a random sample and if I'm mainly looking at LDL and TG is only mildly elevated, then I'm okay with that report. But if the TG comes higher, maybe we'll have to again do it in a fasting state.
Right.
Yeah, I agree with both of them that the cholesterols usually are not significantly variable with fasting and non-fasting, and even the hard and fast rule that 8 hours fasting and 12 hours fasting is not really a mandate for cholesterols. But for
Yeah.
triglyceride, yes, that every hour after the meal matters for triglyceride levels. And there are some literatures to suggest that postprandial triglyceride is also a very good marker of cardiac risk. So you can not disregard that report. You can still interpret based on the risk factors, but I think that needs a re-verification, especially when we are thinking about the dyslipidemic risk overall.
Except that we haven't yet got established cutoffs for postprandial triglycerides, which is a risk. But the other issue is even non-fasted, if you're looking at non-HDL, LDL. LDL and non-HDL, and just HDL. Those can all be done non-fasted, and
Yeah.
you still can have a fair amount of idea about the lipid status, right? So maybe Dr. Pratosh. So this Dr. Ashok Kumar Agarwal from Chandigarh, role of fructosamine estimated or glycated albumin in general practice, especially in anemic or patients with CKD.
Yeah, especially if there is a HbA1c glucose mismatch in practice. Nowadays go to test is CGM, where you could actually get a lot of clues whether the patient. But CGM, we are measuring the interstitial glucose. So for the chronic hyperglycemia impact, the alternatives are fructosamine and glycated albumin. But the lab availability and assay related issues you need to consider in that, and even cutoffs, we are not very practical cutoffs like HbA1c. So I always prefer CGM derived measures with correlation with the glucose parameters rather than fructosamine nowadays. But fructosamine could be done, but only problem I face is the cutoffs and lab assay related issues.
Right. So we are already what, almost more than an hour, so we should be winding up soon. Maybe I'll ask Dr. Vaishali about vitamin B12. Again, this is covered in many of this routine package tests that you do. Vitamin B12, vitamin D, everything is done. So, and you find a lowish vitamin B12, let's say 150, 160, 70, where the normal maybe from 220 onwards. So what do you do uh, in these individuals?
So, B12 deficiency is very common with insulin resistance and metabolic syndrome in general. So, it is known insulin resistance one is an important factor for altering this B12 metabolism. So, commonly we come across with obese patients with PCOD, with metabolic syndrome patients, and patients who have undergone bariatric surgery who are on metformin therapy. So, these are the populations where B12 deficiency is inevitable. Most of them have a recurring one. So they have a lifetime B12 deficiency. So they need a long-term supplementation. Depending on the deficiency degree and the symptomatology. So if you have a frank, high, very low vitamin B12 deficiency, which is manifesting clinically in the form of macrocytic anemia or in the form of neurological manifestations, then it is better to treat with injectables and high dose injectables, at least 1 milligram alternate day for 3 to 4 weeks. And if the patient is thereafter maintained on oral therapy with at least 1,000 microgram per day, and ideally most of them would again manifest with deficiency if they have stopped. So it is better to continue them in the long run. Also important to understand that metformin and other medications can hamper the B12 level. So especially patients who are taking long-term metformin, like PCOD patients or infertile patients, they also need to be supplemented along with this. And one more important point is that isolated folate supplement is to be avoided. You need to give it with B12 deficiency, because only folate supplementation may worsen the B12 deficiency and actually precipitate certain features. So all these points kept in mind, it's a very common nutritional deficiency, not only B12. We have data with iron also and with vitamin D also. So all these three are very common, iron and vitamin D and B12. So all these needs replacement in insulin resistance patients.
Right. And of course, it tends to be more common in those who are vegetarians. Uh, the sources, the dietary sources are less for them. Right.
Even in non-vegetarians, sir, the liver is the source. So I'm sure that people don't consume that amount of the liver or non-veg in that form. So even they would require, we've seen a lot of non-vegetarians also who are insufficient. So that's one more point.
Right. Yeah. So I think we had a fair amount of discussion about common blood tests giving us a clue to endocrine disorders. And I really thank all of our panelists. I know Dr. Ankur had to leave a little bit early, but profuse thanks to him, as well as to Dr. Pratosh Gangathar, Dr. Vaishali Deshmukh, and Dr. Shahana uh, Shetty for their contributions, and of course to our many colleagues and friends from across the country who have joined in and keep this discussion alive with their interesting practical questions. And of course, I must thank the INTAS, the Zenith team, for encouraging us to hold this session month after month. So I now hand over back to the organizers.
Thank you, sir. Thank you for your kind words. And I just want to share the number. The login which I can see right now, it is 1509. Doctor has login for the Tuesday session. I would like to sincerely thanks to Dr. Ankur sir and Dr. Sahana ma'am, Dr. Purushottam Gunnar and Dr. Vishali Deshmukh ma'am for the excellent discussion for the this today's webinar and sharing the valuable expert opinion for today's this session. And my heartfelt thanks to Professor Shubhankar Jodhi sir for the smooth conducting of Endocrine Talk Show, which is the 37th edition. Finally, I would like to thanks to all esteemed delegates for their taking out their valuable time on Saturday evening and attending the webinar. Thank you, sir. Thank you very much for your time. And I wish that the times to come when we will keep discussing this kind of interacting session under your guidance. Thank you, sir. Thanks a lot for your time,
Thank you
sir.
very
And
much.
good night, sir.
Thank
Very
you.
good
Thank
night.
you. Thank you, sir.
Thank you.
Good night.
Thank you, sir. Good night, everyone.
Thank you.
Good night.
Thanks. Thank you. Thank you, ma'am. Thank you, Vishal ma'am. Thank you. Thank you.